So good morning, and my name is Ann Olson. I'm thrilled to be here with you today and talk about my favorite measure, which is GG0170C. As Alan talked about yesterday, GG0170C is one of the few measures that is identical from setting to setting. So it's exciting, I think, that we are really putting into practice what the Impact Act has put forth, and very happy to share with you the best way to score this moving forward. So our objectives today are to really demonstrate a working knowledge of GG0170C. We've followed this same format throughout, so we're going to be talking about the intent of the measure, the coding options for GG0170C. We're going to apply the instructions so that you can accurately code or score practice scenarios, and I think all of the speakers have emphasized how important it is to do the practice piece, so we'll be doing that as well as doing the case study later today, as Ann Spinard mentioned. And then talk about some of the common stumbling blocks with this measure. There have been several questions that came through that CMS has provided guidance on, so we're doing very specific scenarios that will address those questions. Excuse me. I want to emphasize also, as Kathy Roby, my colleague, had said, how important it is. You are the train the trainer group here, so really bringing this information back to your staff, to your team, so that you really can drive that proficiency with the OASIS and with this measure. We also want to, again, emphasize that action plan and trying to make this really something that you take and move forward with and have an action plan so that your staff really can embrace what you've learned here today, over the last 2 days, actually. So the acronyms, there's not as many used in this presentation, so you have a little break there where I'm not going to give you a test. These are the acronyms that are used in this presentation and many of the same ones that have been used in the presentations prior to my coming up this morning. And also just to again state that we're talking about scoring the OASIS. We use the word code or coding. I know that Kathy Roby went through this pretty specifically, so I'm not going to belabor the point, but we are not talking about the ICD-10 coding. We do use the word code and coding throughout the presentation, but that's not to be confused with the ICD-10 coding. We're talking about how you specifically would be scoring the OASIS and GG0170C. So you've all heard about the importance of risk adjustments and covariates. Kathy took a great overview of the M1028, M1060, and M1620 as covariates to the percent of patients with pressure ulcers. GG0170C is the fourth that we're going to be talking about today, lying to sitting on the side of the bed. As you all know, this went into effect in January of this year, and the time points that it is completed is the start of care, the SOC, and the resumption of care, or ROC. I know you've all been loving doing this, right? It's how do your staff feel about it? Is this the favorite one, or is there a lot of confusion on it? How many are confused with GG? Not at all. They're all. Did anyone want to come up and do the presentation for me, and I'll just go have some more coffee? I think it can be pretty direct, but it's important to review the scoring. I know that someone had come up about how it's the reverse scoring to the other items in the OASIS. So, again, it's really just important that your staff understand the scoring and that they are not confused over some of the distinguishing pieces between each score, each level, as we go through the tool. So the item intent is something that I believe, and I hope you all agree, that we've been doing in home care for a long time, long before GG came into place. It's important that we assess whether a patient can safely get in and out of bed, right? That's something that we've done in home care. I've been in home care for over 25 years. It's a critical piece because that's a safety issue. So GG0170C really is just quantifying that. We're identifying the patient's need for assistance, the mobility task of moving from lying on the back to sitting on the side of the bed with their feet flat on the floor with no back support. So that's the technical definition and what we'll be talking about today. And another topic about mobility limitations and how that can contribute to a risk for a pressure ulcer. Many of us here are nurses. I'm a nurse. I know I'm joined by many of you who are nurses as well, and this is something we learned in nursing school long ago, right? That if someone's immobile, they're at more risk for a pressure ulcer. That's not rocket science. So that really is one of the critical pieces and one of the main points for the rationale of GG0170C. It's also, obviously, immobility would increase the risk for development or someone that does have a wound already and affect wound healing. So again, it is very much a contributor to that, which is why it is a covariate to the risk for pressure ulcer and why it's so important that we get the scoring correct when we're completing the OASIS. I mentioned that the time points are the sock and rock. We all know that the start of care needs to be done within the first 5 days, and then the rock within 48 hours of a patient's return from an inpatient admission. So what are the steps for the assessment for GG0170C? The first, there are actually 5 that we're going to go through. The first is to assess the patient's self-care status based on direct observation and/or report by the patient, caregiver, or family. So this, again, that observation piece is so key, and I hope that you all agree that as a best practice in home health care is to have the patient demonstrate their ability. We would always want to assess whether they can get in and out of the bathroom safely. Similarly, you want to assess and observe whether they're able to get in and out of bed independently. And that really is what GG0170C is requiring, that you observe and assess the patient actually perform the task. However, there will be instances, and CMS recognizes this, and it is in the manual, that you can listen to the patient, listen to the caregiver, do a clinical assessment of the patient, and there may be instances that it is acceptable not to observe the patient actually perform the task. In your clinical judgment, with the adequate information that you've gathered, you can answer the question without actually observing them perform the task. But that would be the exception, not the rule. And I would encourage all of you in your education to your staff to always emphasize how important it is to actually observe the patient if it's safe for them to do that. So that goes to the second step of the assessment, which is safety. And you've heard that yesterday and with Kathy's comments today. Safety is always a key piece. So you do want to have the patient perform the activities independently. But if it's not safe, obviously, we're not going to require them to do that. We're also going to be assessing whether caregiver assistance is required, and this is really a critical part of what GG0170C is doing. So we're assessing how much assistance the patient might need to move from lying to sitting on the side of the bed safely. So this is the amount of assistance that we're going to be assessing and scoring on this measure. The other really important piece to remember is that the use of an assistive device to complete the activity does not affect how you score this measure. It's been fun traveling and going in shuttles to different restaurants. We were joined by our friends from New Jersey, and we were talking about this in the van because there is still some confusion as to whether if you use an assistive device, if you use a belt to help move your legs or other devices to perform this activity, can you do that and not have that adversely affect the scoring? And you can. The assistive device does not impact the score. If the patient can do it independently with a device, then they're independent. So again, an important piece for you to know and also to emphasize to your staff that the patient can use an assistive device, and that does not adversely affect how they would be scored on this measure. And last but not least is looking at that category or that assessment in terms of what the patient's usual status is. So we all know that our patients in home care do have fluctuations in terms of, how they're feeling from one day to the next. And while you're in that window of completing the OASIS, you really always want to use that usual status, not their very best performance or not their least independent performance. So use what the patient's most usual performance is when you're assessing and scoring this measure. So this is the actual screenshot of the tool, and we're going to be going through basically all of the different scores. You can see that you've got GG0170C1, which is the highlighted area. This is actually the assessment of the performance. The second column, which I know you're all familiar with, is that somewhat controversial discharge goal, and we'll be talking about that as well. But the first area that we're going to be discussing is C1, which is the sock rock performance. So this is a standardized item, as I mentioned, as Alan had highlighted in the overview of the Impact Act yesterday. So this sock rock performance is used as a covariate for the quality measure for risk for pressure ulcers in all of our post-acute settings. So it's the identical measure. It looks just like that in all of the tools that our colleagues use in the different settings. And the scoring or coding instructions, we'll just go through these briefly and then dive a little deeper into them with some examples as we go forward. So to code GG0170C1 for sock rock, you've got these 6-point scale that you're able to use. Code 6 is obviously the independent scale. 5 is that setup or cleanup assistance. 4 you would use for supervision or touching assistance. Code 3 is designated for a partial or moderate assistance from a caregiver. Code 2 is for substantial or maximal assistance. And code 1 is for a dependent patient status. I mentioned in my opening comments about the controversy about the way the scale is reverse as compared to some of the other scales in the OASIS. This is a scale and a measure that, as I mentioned, is used in all of the settings. It was established based on a consensus among clinical therapy experts and tested across all settings. So that is why the score is in the format that it is, and it is something that has been tested. So we don't have flexibility with that. We couldn't change it. It is what it is. So that is why the score is based the way it is. And then we have these 3 other scores, as you all are familiar with, and these are if the patient does not attempt the activity, and when the caregiver does not complete the activity for the patient. So these scores, again, are very important and different, so you want to be sure that you understand them. Code 7 is when the patient adamantly refuses to do the task, and you don't have that adequate information that I mentioned that would enable the nurse or the clinician to make an assessment, a determination. Code 9 is for when it's not applicable for a particular patient, and we'll talk about the difference between Code 9 and Code 88, which is when the patient, we do not attempt this task due to a medical condition or to a safety concern. So going through the different measures and the different scores so that we all are on the same page, we're going to first talk about Code 6. And Code 6 is independent if the patient completes the activity by themselves and there's no human assistance. And that's really the key term, is that human assistance. So as I mentioned earlier, they can use an assistive device, but there is no caregiver assistance, no family assistance. The patient's able to get up and get out of the bed, move from lying to sitting on the side of the bed without any human assistance at all. I like to use the example of using a belt as an assistive device. One of my colleagues, we've talked about how after surgery, it was actually my agency that helped treat this colleague of mine at home, and trying to get out of bed to move her leg from the bed to the side of the bed, she was not able to do that. But our therapist at our agency just gave her the suggestion to use a belt. And the belt she put under her ankle and was able to lift her leg and then move that to the side of the bed and sit up and sit unassisted on the side of the bed safely. Using that belt made her independent. It did not, it was not human assistance. So that would be considered 06. That would be an independent transfer. It's not something that, again, required her family member or required a caregiver to be there. So in any instance that a patient does use an assistive device like that, but they're still able to do it independently, they would be scored 06. There are also some of our patients that might be shorter and they need a step stool at the side of their bed. As long as that's something that's in place and they don't need to have someone bring the step stool, but if they have that in place all the time, that's part of their normal routine to get in and out of the bed safely, then that would be considered 06 as well. So again, that assistive device, as long as the patient is able to manage it themselves, they're still considered independent while scoring this. Code 5 is, and again, we're just going, one step. So this is when the patient might require a setup or a cleanup assistance to help them do this task safely. So this would be in a situation where the caregiver is providing assistance either prior to or after the activity. And that's really an important distinguishing factor. So if your patient, for example, had a shoulder issue and they needed to put a sling on their shoulder so that they could perform the activity, and the caregiver would just hand them that sling, but the patient was able to put the sling on and then move from lying to sitting on the side of the bed safely, then that would be considered a score of 5, because the caregiver is not helping the patient during that movement, during that activity. They're just providing them with the sling so that they then can do that on their own. So that's considered a setup. It would also be if the patient wanted to remove the stool once they had gotten up and the caregiver has to put the stool in place or move it out of the way, then that would be considered after the activity, so you would score that as a 5 as well. Code 4 is moving to the next level, which is including supervision or touching assistance. So this is a lot of times our family members and caregivers, our home health aides, might be giving some verbal cues or touching or steadying the patient as they're moving from lying to sitting on the side of the bed. So this is something that could be provided throughout the activity. So again, that's different than Code 3, which was before or after. And in this example, the patient, you would be giving some cueing, possibly encouraging the patient. Maybe it's someone that doesn't really want to get out of bed. I know we've never had that, right? You've got a patient that is really very comfortable and would prefer to stay in bed versus getting up, but it's time to move and get on with their day. So they need some coaxing, talking them through. You can do this. You can move your legs. It's not lifting the legs, but explaining to them and encouraging them, possibly guiding their back, putting your hand on their shoulder, but not physically contributing to the effort that it takes. So that is really the difference with Code 4. So you're giving that contact guard or steadying or some verbal cueing, but not physically helping the patient really perform that activity from lying to sitting. Code 3 is moving again to more of a physical assist. This is really where the caregiver would be providing less than, and that's in caps there. So these are important distinguishing points. Less than half the effort for the patient to move from lying to sitting on the side of the bed. And then Code 2 is just taking it the next step so that it would be when the caregiver provides more than half of the effort. And of course, in that instance, the patient is providing less than half. So again, we're moving toward more dependence on caregiver support. Again, emphasizing that this is during the activity. It's not before or after. The patient requires the assistance throughout the activity, and more than half of the effort is provided. So it would be really lifting the legs, really helping with the trunk, helping them to sit and sit safely on the side of the bed. That would be scored as a 2. And then Code 1 would be your fully dependent patient. This would be when the caregiver must provide all of the effort. Many times this is a patient that requires actually the assistance of 2 or more caregivers to do this activity safely and to complete the activity from lying to sitting on the side of the bed to get out of bed. So now we're moving on to the coding instructions, and again, we're on GG0170C1. So this is for the assessment, where you're looking at when the activity is not attempted. For Code 7, this is when the patient refuses to complete the activity, and you don't have adequate information to score the patient based on your assessment. A good example, I like to give the example for me. I actually had bilateral, this must be a Qualidime thing because Kathy has her knee brace, and I had bilateral knee replacements. So it's a requirement at Qualidime that you have to have knee problems, or you have to be named Ann, because Ann Spinard, Ann, lots of Anns and lots of problems with knees. But when I had my bilateral knee replacement, and my therapist came in to ask me to get out of my recliner and get in and out of the bed, and this was before GG, but she made me move from the chair and go into the bedroom and wanted to see that I could get in and out of bed safely. And I can tell you that I did want to refuse to do that because I was very comfortable in my electric recliner and preferred not to have to do that. But she encouraged me and said, Ann, you really need to do this. I need to make sure you can do it safely. So we're going to just walk in and I'll see how you're doing. And she really encouraged me to move and get back into bed, which is what we need to do. Most times when you're performing this assessment, you get to the person's house and they're not necessarily still in bed, right? I mean, we could ask that they stay in bed until we get there, but most often they're already sitting up or maybe in the kitchen or sitting in their recliner. So you do want to encourage the patient to perform the activity, but there are instances, and we do have a few scenarios that you'll see where the patient might refuse, but you do have, you've exhausted and you found that the patient really, you don't have enough information to score the tool and score this measure, then you would use 07. So this is something that, again, takes into account the clinical judgment, and you have tried to have the patient perform this activity, and they are adamantly refusing to do it, and you really don't have enough information to score this measure, then you would use 07. For code 9, this is really when the patient did not perform the activity prior to this current illness. And that's a really important piece when you're instructing your staff. So if your patient did not do this before you opened them to home care, then it would be unlikely that we would be asking them to do it when we're there during this episode of care. So that would be when you'd use the code 09, that it would be not applicable for the patient to try to perform this task because they didn't do it before you had been taking care of them. So why would we expect that they're going to do it now? So that was when you would be using the code 09. And then code 88 is when you're not attempting it because of a new medical condition or a safety concern that's related to this current episode, and you're not attempting it because safely you cannot ask the patient to perform the task of moving from lying to sitting on the side of the bed. So that's when you would use code 88. We did get several questions on this in the FAQs that we call it when we did our presentation in November. So we thought it would be helpful just to put these side by side. And again, just trying to emphasize to you that code 9 is really when it's not applicable because of a prior illness that the patient had. So an example of that would be a quadriplegic patient that had an ongoing need for a Hoyer lift. So if that was their pre-existing condition prior to us going in and opening them to home care, so you would not be expecting them to all of a sudden be able to do this task. So it really is not applicable, and you would use 09. Code 88 would be, again, that it's due to a new medical or safety concern. So an example of that might be someone with a compression fracture that they're required to be on bed rest because of this current condition, their current episode of care. So it would not be safe for us to attempt the task, and you would use the code 88. And then we have this very popular dash, which is, I think, for us in home care, somewhat of a controversial scoring. It is a rare occurrence that you would be using the dash. It is considered a valid response for this item, and it would be used really if the patient is unexpectedly transferred or discharged or dies before the assessment of the item could be completed. Otherwise, CMS would expect that we're using one of the scores that I've mentioned, either that 0 to 6 scoring or the visit not attempted scores, but you can use the dash if it is a rare occurrence. So just going through these, the coding questions briefly, seeing them visually here. This is kind of the walkthrough. So do they need assistance to complete the activity? No, then you would code them a 6. Do they need a setup or cleanup assistance from one helper? If yes, then you would code them a 5. If no, then you would go to the next. Do they need just some verbal or nonverbal cueing or steadying or touching assistance from one helper? Again, that would be a score of 4. If no, then you would go to the next question and encourage your clinicians to go through this process. The lifting assistance, trunk support, which is less than half the effort, you would score a 3. And if they required more assistance, more than half of the help, then you would be coding them or scoring them a 2. And then again, for that dependent patient, where the helper is providing all of the effort, you would be scoring them a 1 as dependent. And then the visit the activity was not attempted. We already went through these. The code 7, patient refused. Code 9, when it's not applicable. And then code 8 if it's not attempted due to that new medical condition that causes a safety concern. So for the coding tips, and again, these are some of the questions that had come up. The question of whether a patient that doesn't sleep in the traditional bed, and we all have seen that in home care. We had a client at the agency that I was at that slept on a mat on the floor. That was their normal bed surface. So completing GG for that patient would be how they could safely move from lying to sitting and getting up off the mat on the floor. If someone uses a recliner, and many of us have seen patients that's their normal bed surface, the recliner that they stay in 24/7 in between, that would be considered their bed. So you can use that sleeping surface, even though the question uses the word bed. You could use the recliner or a mat, whatever their normal sleep surface is, you can use that to score the tool. Another question was whether a patient's feet do not touch the floor. And I love using the example of my mom, who's this little Italian lady who's shrinking it seems every time I see her, she gets a little shorter. But her feet don't touch the floor, but my mom is very able to move and independently get up, and she's safe without her feet touching the floor. If your patient is able to move and complete this activity, but their feet don't touch the flat on the floor, as the question does designate, they could still be scored as a 6 independent, as long as they can safely do that. The other question is about the step stool. There were a few questions that had come up where the clinician feels that the patient's not safe sitting at the bedside, and then the assistance to either lower a bed if it's a hospital bed, or to place a footstool prior to the transfer. We talked about that, the scoring of the 5, that setup, cleanup assistance. So that would be acceptable if the caregiver is putting a footstool down so that the patient can perform this activity. That would be scored as a 5. And we all understand that in some cases, and we talked about this with whether the patient's refusing, whether you can score this, if someone is not able to or does not want to participate in performing this activity, but you've got enough clinical information to score the tool, you're always going to be needing your clinical judgment, whether it's a safety issue. This is something that we as clinicians and as leaders need to instruct our staff to use clinical judgment to make the proper determination to score GG0170C. So moving on to the discharge goals. So this is GG0170C2. This did get some questions when we presented this in November, and I'm sure some of your staff have had questions on this as well. So this is a standardized item as well. And the discharge goal is not expected. There was a lot of question on this, like, is this going to affect our outcome measures? Is it going to affect our reimbursement? We just wanted to relay the guidance from CMS that the discharge goal is not expected to impact any of the home health quality measures in 2017. It may be used either directly or indirectly in the future, but right now it is just a question that they're using to gather information. So just to be assured that currently it's not impacting the actual quality measures as reported with your OASIS documentation. So for the discharge goal, you can only use that 6-point score. You cannot use the 07, 09, or 88. And that is primarily because you're not attempting or asking the patient to attempt to perform the activity. Basically, you're reporting the discharge goal as you've discussed with the patient and with the family as to what you feel is a realistic discharge goal for this patient for this activity. And like with many things that we do in our assessments, you're really determining this based on a number of factors, looking at the patient's medical condition, looking at what their treatments are, what their motivation to improve is. Obviously, this is a critical piece if we're trying to establish what the discharge goal is for this item. Their anticipated length of stay based on the condition that they have. What was their prior activity? What was their prior mobility status? This is obviously going to help you with scoring the tool. Any other current multiple diagnoses? Any concerns that the patient or the family has concerning their discharge goals? Where do they think they're going to be? And again, what overall are you anticipating their assistance at the discharge? That's how you're going to be answering this question. You can use the dash for this item. This, again, is something that would be a rare occurrence, and it would be if the patient's unexpectedly transferred. Otherwise, you would be scoring GG0170C2, looking at that goal on that scoring of 0 to 6. So if you've got the sock rock coded as a 7, 9, or 8, 8, how do you score GG0170C2 for the discharge goal? This also was a big question. If you can't use 7, 9, or 8, 8, how are you supposed to score GG0170C2? Would you use a dash, or what would you do? And basically the guidance that we received on this is, again, you do not have the option to use 07, 09, or 8, 8. So if you can't use a scale of 0 to 6, and you're looking at a patient that you're not expecting to gain any function, then you would be using the dash in that item. So again, this was a question that had come up, and it was answered by CMS that if in your discharge goal you do not expect the patient to improve and to gain function, then it is appropriate to use the dash in scoring GG0170C2. And just walking through how you would be establishing your discharge goal, when would the code or the score be higher than your sock rock assessment? Obviously, it would be higher if you're expecting the patient to gain functional progress. And obviously, that's our goal 99% of the time. But there are instances that that's not an appropriate goal. But if the patient is expected to improve, which we hope they are, then the discharge goal code would be higher than the sock rock. In an instance where the code was the same as the sock rock, this would really be when it's a medically complex patient that's really not expected to improve. And our goal would really be to maintain their function. So that's where your goal would be the same as the sock rock assessment. Your discharge goal would be the same as the sock rock assessment. And then there would be instances when the sock rock performance code and the discharge code differ where the discharge code is lower. And that instance could be when a patient has a progressive neurological condition, so that you're actually anticipating that the discharge goal will be less than the sock-rock performance. And that is an appropriate answer if, in the clinician's judgment, the patient is anticipated to actually decline in their functional status. So we've gone through the scoring, and we're going to move on to some of the practice scenarios, which we hope that will help to illustrate for you the best way to answer the questions or the scoring for GG0170C. So for this first scenario, when asked to demonstrate lying to sitting on the side of the bed, Ms. A states that while improved, it still requires much effort to get up. She does not want to get up again today, the scenario that we talked about. She states that she needs a lot of help moving in the bed, getting her feet off the side of the bed, and coming to a sitting position. Her son states that he must do most of the work. Based on the patient and family input, an observation of the patient's weakness and pain, the assessing clinician concurs that the patient likely requires considerable assistance to move from lying to sitting on the side of the bed. Based on the patient and family input, on recent progress and observation of Ms. A's general bed mobility and the expected home care length of stay, the clinician determines that Ms. A will be able to independently perform the activity of lying to sitting on the side of the bed by discharge. So we'll start this. How would you code GG0170C1 for sock rock performance? Would you code 3, partial moderate assistance, code 2, substantial maximal assistance, code 9, not applicable, or code 7, patient refused? And you can use your little clickers. Okay. So we have a little bit of a split here. The scoring, the correct answer is B, 02, and that is for substantial maximal assistance. And then for the coding of discharge goal for GG0170C2, we can score that as code 6, independent, code 5 for setup or cleanup assistance, or code 7, the patient refused, or a dash. Okay. And we have a little bit of a split here as well. The correct answer is A, code 6, independent. We had a few people that went for code 5 for the setup. So we'll talk about the rationale there. And this is a little bit of a confusing scenario, so it's good that we're going to talk through this. So although Ms. A refused to demonstrate the activity, we talked about the fact that the nurse, the clinician, can supplement the scoring based on the patient and caregiver report. So in this scenario, the patient described that they were, too uncomfortable to move and complete the activity. The clinician did speak with the caregiver, and they provided the information that it required maximal assistance, that the caregiver had to help the patient to move from lying to sitting on the side of the bed. So in that scenario, the clinician was able to use that clinical judgment to determine that it would be coded as a 02, that it required substantial or maximal assistance. So that is the scenario where you had to decide between whether it was a patient refused or did you have enough information to score this patient. And based on the scenario and the information that the clinician had, it was appropriate to code the patient 02. For the discharge goal, based on, again, the clinical judgment and the patient's prior status, it was determined that the patient, Ms. A, would be able to independently perform the activity by discharge. So again, it's really teaching our clinicians to listen and to use their assessment skills and to put that into action when you're trying to determine the proper score for this measure. So for practice scenario 2, Mr. B pushes up on the bed to attempt to get himself from a lying to a seated position as the occupational therapist provides much of the lifting assistance necessary for him to sit upright. The OT provides assistance as Mr. B scoots himself to the edge of the bed and lowers his feet to the floor. Overall, the OT must provide more than half the effort to complete the task. So your choices are 04, supervision or touching assistance, 03, the partial or moderate assistance, 02, the maximal or substantial, and 01, dependent. So we do have most people did answer the correct answer here. The code would be 02. Again, that's that distinguishing between looking at whether it's more than half the effort or less than half the effort. So in the scenario, we talked about the OT requiring to perform more than half of the effort. So that's why the correct code would be 02, the substantial or maximal assistance. And again, Mr. B required that the caregiver or the OT provide the lifting assistance, and that's the way this scenario was described, more than half of the effort to complete that task, going from lying to sitting on the side of the bed. The next scenario, Mrs. Y is obese and recovering from surgery for spinal stenosis with lower extremity weakness. The caregiver partially lifts Mrs. Y's trunk to a fully upright sitting position on the bed and minimally lifts each leg toward the edge of the bed. Mrs. Y then scoots toward the edge of the bed, placing both feet flat on the floor. She completes most of the activity herself. So again, the choices for GG0170C1 is 4, supervision or touching assistance, 03, moderate or partial assistance, 02, which is the substantial or maximal assistance, or code 1, which would be independent or dependent, excuse me. Okay, so we have 92% who got this correct. The code for that would be code 03 for partial or moderate assistance. And again, the scenario, the rationale for that is that Mrs. Y required the caregiver to provide limited assistance. The scenario ended with stating that the patient provided more than half the most of the effort. So again, that's the distinguishing between 03 and 02. Mrs. Y required less than half the assistance to complete the task, moving from lying to the side of the bed. The next scenario is Mr. W. He states he wishes he could get out of bed himself rather than depending on his wife to help. At the start of care, the patient requires his wife to do most of the effort. Based on the patient's prior functional status, his current diagnosis, and the expected length of stay, and his motivation to improve, the clinician expects that by discharge, the patient would likely only require assistance helping his legs off the bed to complete the supine to sitting task. So we're going to be looking at C1 and C2 in this question. How would you score GG0170C1? Would you code 04 for supervision or touching assistance, code 3, partial or moderate, 2 for the substantial or maximal, or code 1 for dependent? Okay, so we still have some divided answers here. So for this scenario, for GG0170C1, it was substantial or maximal assistance. For GG0170C2, and we'll describe the rationale after, how would you code GG0170C2 for the discharge goal? Would it be 04, supervision or touching assistance, 03 for partial or moderate, 02 for substantial or maximal, or 01 dependent? So that was, I think that's a record there, the 46 to 46, okay. So again, the scenario described for the start of care. At the start of care, the patient required the caregiver to provide, again, it's that more than half the effort, but the patient also did express that he wanted to be able to get out of bed on his own. But the assessing clinician and the patient expected that the functional improvement by discharge, that he would need the caregiver to assist, and they talked about moving the legs to the side of the bed. So that was where you would be looking at for the discharge goal, that it would be coded as a 3 for the partial or moderate assistance. So for the practice scenario number 5, we got Mrs. M is a quadriplegic admitted to home health following a skin graft for a stage 4 pressure ulcer. Prior to this home health admission, she was bedbound, and her caregivers used a Hoyer lift to transfer Mrs. M from her bed to her wheelchair. Based on the patient's prior functional status and the current diagnosis, the home health clinician does not expect that Mrs. M's dependence on a Hoyer lift for transfer will change by discharge. So how would you code GG0170C1, the sock rock performance? Would the patient be scored 1 as dependent? Would they be scored as a 9, not applicable? Code 88, that it was not attempted? Or would it be a dash for this patient? Okay, so we still have a little bit of a split here. The answer for that was code 9, not applicable. Again, the patient had a Hoyer lift prior to us getting involved in home care. So that was a pre-existing condition. They did not do it beforehand. So it would be coded as a 9, that it was not applicable for the patient to perform this task at the SOC or ROC assessment. And how about the discharge goal? Would we code that as an 01, dependent, code 9, not applicable, code 88, not attempted, or enter a dash for the discharge goal? So this is a tricky one. Again, we talked about how on discharge, with the discharge goal, you do not have the 07, 09, or 88 as appropriate scores. So for the discharge goal for GG0170C2, the correct answer for this scenario would be a dash. And the rationale for that, for the assessment on the start of care, Mrs. M was not performing that activity, as I mentioned, to move from sitting on the side of the bed because she was reliant on a Hoyer lift. So the appropriate score was 09 for GG0170C1. And for GG0170C2 for the discharge goal, because you don't have those not attempted scores available to you, you would be appropriate in using the dash for GG0170C2. And the last scenario, Mr. W is recovering from shoulder surgery and usually sleeps in an electric recliner every night. When demonstrating lying to sitting, Mr. W pushes the button on the side of the recliner to return the chair to an upright position. Based on the patient's prior functional status, his current diagnosis, and his motivation, the clinician expects Mr. W will be independent in performing the activity by discharge. So how would you score GG0170C1? You can choose dash, 06, 01, 09, or code 88, not attempted. So this was a great answer here with code 6 being the appropriate answer because the recliner was his usual bed surface. And then for the discharge goal, how would you score GG0170C2? 09, 88, a dash, 01, or 06, independent? So most of you did get that correct as well. The code was 06. And the rationale, again, is for GG0170C1. The patient would be scored as independent because the electric recliner, that was his assistive device. It was his normal bed surface. So that was considered independent. And based on Mr. W's prior functional status and his diagnosis and his motivation, the assessing clinician determined that he would be independent upon discharge. So in summary, we talked about how GG0170C is a risk adjustment covariate for the risk of pressure ulcer. It is a new item, and it does require observation and assessment. You would be using that 6-point scale and the 3 activity not attempted codes. And the use of a dash is a valid response, but considered to be a rare occurrence, except for the discharge goal that we talked about, if they had a pre-existing situation. Again, can't emphasize enough that you do want to look at your current processes and really reflect the addition of GG0170C. Even though it seems like a pretty direct question, we can see by some of the responses that there can be some confusion over how to score this. So you do want to have a very strong education plan for your clinicians and to practice these coding scenarios so that they're proficient in answering this question. And obviously, with all of our measures, looking at our proficiency from an annual standpoint, ensuring the accuracy of the data so that you're considering an annual performance improvement plan based on how you're scoring this measure. We have the same resources listed here, which we have shared with you on multiple occasions, so I won't be going through those again. And we're going to be deferring questions until after Kathy does her presentation. I want to thank you all for your attention. We will be breaking for lunch after Kathy does her next part of the presentation. And here she comes. And we did color code our outfits today with the gold jackets. So thank you so much.